All right, so let's talk about arterial puncture via the radial artery. So I've got a mannequin here that's simulated. I'll turn it on here shortly, but you'll be able to feel the pulse, the radial pulse with that. So indications for doing an arterial blood gas. One, we want to make sure that we can assess the overall adequacy of ventilation. So we're wanting to assess the partial pressure of the arterial carbon dioxide to let us know how effectively or how ineffectively or how overly effectively the patient is breathing. So remember, if they're ineffectively breathing, they're not going to be able to remove as much PaCO2, so you're going to see hypercarbia or hypercapnia with elevated CO2 levels. And remember, based upon your acid-base balance, those elevated CO2 levels are going to drive your pH down, because CO2 has an inverse relationship with pH. A high CO2 is going to drive your pH down. If we're overly effective with our ventilation, then our CO2 is going to be less than our normal 35 to 45 millimeters of mercury range, so we would be hyperventilating the patient at the time, and that can be done iatrogenically with a mechanical ventilator if you happen to set maybe too large of a tidal volume, too large of a respiratory rate, but ultimately you'd have to have an excessive minute ventilation in order for that to occur. So if your respiratory rate were high and you're overly effective, then you would be hyperventilating but hypocapnic or hypocarbic. So your CO2 level would be low, and that would give you a respiratory alkalosis, as opposed to where we started off with what was described first with a high CO2 and a low pH would be a respiratory acidosis. So we're assessing the overall effectiveness or adequacy of ventilation, and you're looking at your PaCO2 with that. You can also assess oxygenation by looking at your PaO2, and then you can also look at like how well the function of your kidneys and stuff are working because of the bicarb. So you can look at that, and bicarb is going to be there to buffer the acid-base system. That is part of the acid-base buffer system. But ultimately what we're going to do here, there are different sites in which you can access to puncture. You can do the radial site, you can do the brachial site, you could do the femoral site. Most places that I've worked at have always required that a physician do the femoral stick. You could do the dorsalis pedal artery, but nonetheless, the focus of this video is going to be an arterial radial puncture. So simulated here is the left hand of a patient. Typically, if I'm going to go in and stick someone, I prefer to stick. I'm right-handed, so I prefer to use my right hand when I prefer to stick someone's right hand with my right hand, because anatomically it lines up better. I always will walk in and explain myself to the patient, introduce myself to the patient, let them know who I am after checking their chart, seeing if there was any contraindications or anything to that effect, to make sure that it's okay to proceed with the stick. But I prefer to stick their right hand if they can be stuck in the right hand, because anatomically lines. So if I always tell them, I'm going to rest my hand in yours, and then you'll feel me feeling around for your pulse. Well, notice how, with this being a left-handed hand model, if I rest my right hand in that hand, when I get ready to stick, I'm more at an angle where I would fit better over the ulnar artery. So ultimately, if I move this around a little bit, I can stick left-handed, because if I rest my left hand in their hand, then now with that syringe in my hand, I'm going to line up better over that radial artery. Because this is a mannequin, I feel pretty good with my chances of being able to stick it right-handed. So I'm going to turn the mannequin so that. But in real life scenario, if there's no reason why the patient can't be stuck in their right arm, because I'm right-handed, anatomically I feel like I line up better to stick them right-handed. But I do, like, if I got to stick their left hand, most time I'll utilize my left hand to stick. You'll notice I don't have gloves on in this video, because I don't want the gloves to get in the way of obstructing the view or anything to that effect. But you would obviously wear gloves with an arterial stick. You also want to assess for collateral circulation. So you'd have your patient hold their hand up above the level of the heart, at the level of their heart, and you'd ask them to make a fist. So you'd have them make a fist, close their fist, blanch their hand out, and release it, all the while you're compressing the radial artery and compressing the ulnar artery as well. So with both of those compressed, you have them make a tight fist, squeeze, and kind of blanch their hand where it kind of whitens up a little bit. And then what you do, have them release their fist, and then simultaneously you can release the ulnar artery. And while releasing the ulnar artery, within a few seconds, you should notice that the hand begins to pink back up with the radial artery still occluded. So this lets us know that where the brachial artery bifurcates into the radial artery and the ulnar artery, that we have collateral circulation. And you want to make sure that you've ensured collateral circulation, just because if you were to do some damage to that radial artery by sticking it, you would want to make sure that they would still have good blood supply to the rest of their hand. So you've got various amounts of ABG kits or arterial blood kits, ProVent. This one's vented already. Some of them you can press the plunger down and it'll pump back. Some you position the plunger where you want it, and then it should fill automatically there. But this is one of several different types of ABG kits. This one, it looks like, comes with an alcohol prep, a 2x2 gauze. It comes with the Band-Aid. I don't ever use the Band-Aid. I always hold pressure to make sure that the bleeding stops. And then you've got your needle with a heparin tablet inside of it. You've got a syringe. You've also got a cap over the needle, protective safety cap. And then you've got the cap for the sample as well. This one also comes with a biohazard bag and a patient label, which is all things that are good to have so that we can send our sample off after we've gotten it. So I'll open that. I'm going to remove the contents. I've got this bag. I'm going to set it aside. Patient label. Nowadays, you're going to have probably through the Epic systems or what have you in the hospital, you'll have a manually printed label that you got to go through and scan, what have you. But we'll set this aside too, because I do want to label that and send it off. You've got your alcohol prep pad. Again, you've got your Band-Aid. I'm not going to mess with the Band-Aid. And then we have our alcohol prep pad and a gauze that we can utilize. I'm going to use both of these here momentarily, so I'll set those aside. And typically, in the hospital realm, you might have a sheet or something that you would set these items on to help keep them relatively clean. You've got this cap, set it aside so that you can get a hold of it afterward. And then you've got your actual syringe. So the syringe, you've got this protective cover over the syringe. So I always like to make sure that that's pulled back. And then if this were in a real situation, if you drop something on the ground, it was contaminated, make sure that you go and get a brand new one so that you're not utilizing dirty equipment on a patient. So I'm going to pull this back to, you could do 1.5 cc's, you could do 2 cc's, and that's how much blood I want to make sure that I get back for my sample. Also, you want to make sure when you stick that the bevel of the needle, and I'm going to uncap it so that you can see, but the bevel of the needle is where it opens right there. So you want to make sure that that bevel is turned the same direction as the top of your protective cap, because when you go do your stick, that protective cap could get in the way of your visualization. Another thing I want to show you too, let me slide this out of the way, and I apologize, I already did a no-no with you with this, but you should never recap a needle like that because you could potentially stick your finger. So always utilize the scoop method if you're going to recap a needle. That way you can get the cap on there, and then you can take and press this up against a hard surface to put the needle back, to put the cap back on the needle. But after you're done with doing your stick, pretty much all you need to do is fold that over the needle, and then you're pretty much done anyway. So I'm going to put my mannequin back in view. I'm going to turn the compressor on so that I get a palpable pulse, and then we'll get started. I'm going to assume you've already done your common procedure elements. We're just getting right to the arterial stick. So we'll look at pulling the alcohol prep out. What I'll do is set the 2x2 gauze aside so that I can utilize that to withdraw my needle shortly. I'll explain to the patient what I'm doing. You're going to feel a little bit of cool sensation to the touch. It's an alcohol prep. I'm cleaning the site. What I will do is clean the site where I'm going to be sticking, And then I will also clean with, and again, I don't have gloves on right now, but in the hospital, anytime I stick somebody, I've got gloves on. I always clean the fingertips with which I'll be palpating the radial artery with. So now that I'm ready to perform the stick, I've gotten my syringe ready, I've pulled it back to what I want my fill volume to be. Going to remove the cap, set the cap aside, and now what I like to do is just tell the patient that you're going to feel for your pulse, and I'll feel until I can feel that pulse back and forth a good bit, and then I will actually move my fingers to the right until I lose it, and then I'll move my fingers back across it until I lose it again. That way, hopefully, I'm centering the overall pulse in the middle of my finger so I can visualize where I want to be able to stick the needle at. So now what I'm going to do is tell the patient, all right, here shortly you're going to feel that. I also pray before every one of these that I do. I think it helps me. You do what you want to. So we'll do the stick. I've pinpointed where I want to. Let the patient know you're going to feel a big stick. Hold still. Now keep in mind, I've got my fingers like that, but you want to make sure. Some people will stick in between their fingers right there. I never do that. I always utilize my fingers here so that I can watch what I'm doing. And you want to make sure that you control that hand, because if the patient were to flinch or anything like that, you stand a chance of sticking yourself with a dirty needle, and that's no good. So I'm going to rest my hand in yours. You'll feel me feeling for your pulse. I'll let you know right before the stick happens. Okay, big stick. Enter the skin, into the artery. And now you get your flashback, and you'll see that your sample begins to fill. Let me see if I can change this a little bit so you can see that. Now, this is a little bit trickier than it's going to be on a real patient, but this seems to be filling pretty well. So I'm going to allow my sample to continue filling, all the while holding the needle still so that it doesn't slip out of the artery. If you've got someone that's filling relatively slowly, your blood should be a nice cherry red color if you're truly in the artery. If it's dark, it could be venous, but given some of the patient populations we've taken care of in the past, especially with COVID, you have true arterial blood and it be just as dark as venous blood as you think, because the O2 level is not that great within it. So just another moment or two, this is going to be full, and I'll be ready to withdraw my sample, and you'll see that that's going to, there we are. So now I'm ready to withdraw. So what I'm going to do, I'm going to put the gauze pad there, apply pressure, pull the needle out, making sure not to stick my finger, and then you can take, not against the patient's arm, but I've only got a limited viewport here. So now you can take and cap that syringe, so put the safety mechanism over the syringe. Now what I'm going to do is locate that little blue cap that we had talked about, and all the while holding pressure, I can remove my needle, set it aside, get ready to drop it in a sharps container. I can place this cap over that. You want to make sure any air bubbles goes to the top, so you can tap it on, and I tapped it here. Yeah, I wouldn't tap that on the patient, but tap it to the side, make sure that you've got the air bubbles toward the top, and then go ahead and push the blood up. So while you're holding pressure, if you've already pre-filled out your label, then you can label your syringe, place it in the biohazard bag, and send it off. When you get ready to run your sample, and you're going to hold pressure until it stops bleeding, I would check again to make sure that we're no longer bleeding. Your data arc says hold pressure up to 5 minutes. If someone's on heparin or anything like that, or they've got low clotting times, it may be possible that you're going to need to hold pressure for a longer period of time. Or depending upon how low their platelets are, how much heparin they've gotten, it might be contraindicated altogether to perform the stick. So that'll be dependent upon your hospital policies and so forth. Now, with the label on, I'm going to remove this off. But when you go run your sample, I'm going to turn this compressor off. When you go run your sample, if this is sat for any period of time, you may see that you get like a clear thin fluid that begins to form in there. So what you'll need to do is take and roll that pretty vigorously back and forth before you run your sample. You may even want to turn it up and down, back and forth, and then roll it again. And then you're able to run your sample. If it's going to be a little bit before you can run your sample, you may want to place this in an ice bag or a chilled bag so that the metabolic processes and stuff slow down ahead of time. But that is your arterial radial stick. And one thing I want to mention is if you're in the arm and you miss the artery, we're gonna, for the purposes of our protocol, you get 2 sticks and 2 redirects per stick. So if I go into the artery and I miss, I don't get anything, I get no flashback. Then what I'm gonna pull the needle back until, you don't want to pull the needle completely out, because if you pull the needle completely out, then that's a stick and you didn't get to redirect. You don't ever want to re-stick with the same needle. You'll pull the needle out just until the bevel clears the skin. You don't want the bevel to clear the skin, so keep the bevel in the skin, and then you would redirect your angle, all the while kind of feeling where that pulsation is at, so that you can visualize in the arm where you want to do that. Now, you may get to a point where you have to utilize a Doppler or even utilize ultrasound to kind of visualize where you're sticking anyway. Some people, you might not feel much of a pulse anywhere. But ultimately, without being terribly verbose, that is the radial artery puncture. Thank you for your time and attention.